Welcome to Omnicurus Originals. We are celebrating the Diabetes Awareness Month. And today we have Dr. Sushil Jindal with us. Dr. Jindal is a present chairman of RSDI Madhya Pradesh chapter. He is one of the senior most endocrinologists and diabetologists of Central India, who has been successfully looking after Jindal Diabetes and Hormone Center in Bhopal. He is currently working as professor and head of Department of Endocrinology, People's College of Medical Sciences, Bhopal. Dr. Jindal has 20 international publications to his credit, in addition to 2 chapters which he has contributed in RSDI textbook of diabetes. He is a chief editor of Hindi Diabetes Education magazine, Madhumay Vani, and his website. Dr. Jindal has successfully held post of an organizing secretary of ECI Con 2013. And he's also a physician to the governor of Madhya Pradesh. Welcome, Dr. Jindal. The stage is all yours.
So friends, good afternoon. Greetings from Bhopal. Today I'm going to talk about a very interesting topic that is clinical utility of C-Peptide test in management and diagnosis of diabetes. So we'll be talking about C-Peptide test. Many of our friends may be using this test, but some may be finding it difficult to interpret, and some may be not using it, but it's a useful test, and so we'll be talking about it. So let's start with a case, maybe a very common patient in day-to-day practice. This is gentleman, Mr. A.K. His age is 20 years, and he presents with the history of tiredness, increased frequency of micturition, particularly during night, and he is also losing weight. And when you see his family history, his paternal aunt and paternal grandfather are diabetic, and his height is 172 centimeter, his weight is 71, so his BMI turns out to be 24. He has no acanthosis nigricans. And when we see the possibility of any secondary diabetes, there is no history of any abdominal pain to rule out the possibility of pancreatic diabetes. And he is not taking any drugs which can increase blood glucose levels like steroids. In investigations, we found that his blood glucose is fasting to 30 milligram per deciliter. The glucose postprandial is 394. And his urine ketone shows a mild ketonuria in the form of 1+ ketone. The question arises that what is the diagnosis? Definitely patient is suffering from diabetes. He is having symptoms for last few months. So can he be a type 1 diabetes? Yes, because he has started his diabetes quite young. He's not obese. There are no telltale symptoms of any insulin resistance, so we can say that there is a possibility of type 1 diabetes. But even we keep seeing patients of type 2 diabetes who present quite young nowadays. So can he be type 2 diabetic? Yes, he's having a family history of diabetes in the form of paternal aunt and grandfather being diabetic. He's not very thin also. Normally we expect type 1 diabetics to be having BMI of less than 19. So his BMI is quite above that. So he can be a type 2 diabetic even. Now we said that he is having symptoms, say if symptoms are persisting for last 6 months, and he has not gone into ketoacidosis. So even LADA is very much possible. And last possibility is MODY, where we say that if there is a strong family history, say presence of diabetes in 3 generations, then we can say that patient may be suffering from MODY also. So here comes the very handy test, which is known as C-Peptide test. So we'll be learning something about C-Peptide test in this lecture. So the beta cells, they synthesize insulin by their genetic sequencing, and so they produce actually pro-insulin molecule first, and this pro-insulin molecule is then broken down into insulin and C-peptide, and both are then secreted into the bloodstream. So with each molecule of insulin, there is a secretion of one molecule of C-peptide also. And so we can measure either insulin or C-peptide in the blood to see the health of the beta cells, whether they are able to produce enough insulin or not. So this test may be very useful in certain clinical situations. Now let us see something about the physiology of C-peptide test. As we said that after cleavage of proinsulin inside the beta cell, the 51 amino acid insulin and 31 amino acid C-peptides are co-secreted, and they are an equimolar concentration, equimolar amount, that is each molecule of insulin. With each molecule of insulin, there is one C-peptide which is released in the circulation. So if we measure C-peptide, that will indirectly reflect the production of insulin also. Now, the circulating half-life of C-peptide is approximately 20 to 30 minutes. So it's having a long half-life in the form of 20 to 30 minutes. But as compared to insulin, the half-life of insulin is just 3 to 5 minutes. That is, if somebody is completely deficient of insulin and you are giving an insulin infusion, and for some reason the drip goes off, or there is the vein is out, the cannula is out of the vein, then patient will very quickly again become zero insulin or insulinogenic. So the half-life of insulin is very, very short as compared to C-peptide, which has a half-life of 30 minutes or so. Now, half of the insulin which is secreted by beta cells gets used and metabolized in the liver in the first pass, whereas C-peptide has negligible hepatic clearance. So we know that the pancreatic endocrine pancreas, it secretes its hormones into the portal circulation, and portal circulation brings those hormones into the liver, where a major chunk of insulin which is produced by the beta cells is utilized and metabolized. So almost half of the insulin which is secreted through the pancreas is actually used up by the liver, and only half goes into the peripheral circulation. So when we measure it in the peripheral circulation in the venous blood, maybe that very little amount comes in the peripheral circulation as compared to what was secreted into the portal system by the beta cells. But C-peptide, because it has a very little hepatic clearance, comes in much bigger amounts in the peripheral circulation. And so if we measure C-peptide, it will be a much better reflection of beta cell health and beta cell's ability to produce insulin, because it's not being cleared by the liver. Now, C-peptide is mainly metabolized and cleared in the kidneys. So whatever C-peptide is circulating is mainly cleared by the kidneys, and 5% of the secreted C-peptide appears unchanged in the urine. So this means that if somebody has some kidney problem or kidney disease, then the clearance of C-peptide will not be efficient, and so the C-peptide levels may be high in patients who have compromised renal functions. And secondly, 5% of the secreted C-peptide appears in the urine, so we can also measure C-peptide in the urine. Now, circulating C-peptide peaks at about 90 minutes after the start of meal. So as we know, when we start eating, the beta cells get stimulated, they start producing more of proinsulin, which gets broken into insulin and C-peptide, and both are secreted in the circulation. Liver uses insulin to great extent. C-peptide is cleared from the liver without any much extraction, and this appears in the peripheral circulation. And when we measure it in venous circulation, the peak usually reaches some 90 minutes after the start of meal. In a healthy individual, the fasting C-peptide level is 0.9 to 2.5 nanogram per ml, and postprandial, that is stimulated C-peptide level, is approximately 3 to 6 nanogram per ml. Now remember that these figures may change from laboratory to laboratory. The nature of the test, the assay method which is being used, and so there may be some variation, but these are the usual, the accepted range of fasting and stimulated C-peptide. Now, why C-peptide is a better reflection of beta cell function? Now, you may ask this question that we have very good assays available for directly measuring insulin. So why not we should measure insulin and then that may give a direct evidence of the health of the beta cells. But plasma C-peptide is a better method of assessing beta cell function than plasma insulin. Now, this is because there is a negligible first pass metabolism in the liver of C-peptide. C-peptide has a longer half-life and constant rate of clearance, and it has more stable and 5 times higher concentration than insulin in peripheral circulation. Now, we know that clearance of insulin is different in fasting state, and it's much higher in the postprandial state. So insulin clearance keeps varying according to whether patient is fasting or fed. And so the peripheral levels of insulin may not give you a very correct and accurate uh, uh, indication of the amount of insulin being secreted from the beta cells. While when we consider the C-peptide, there is negligible removal of beta cell in the liver. It has much longer half-life, and its rate of clearance is almost stable because it is being removed by the kidneys. So it's almost stable rate of extraction from the circulation. And so we can depend much more on C-peptide than on insulin to see the functioning level of beta cells. Now, it more accurately reflects portal insulin secretion than the peripheral insulin. Now, we know that because insulin is being extracted in liver, and there are also some differences in clearance rate of insulin at various points of time. And so it reflects the portal insulin secretion much better than the insulin itself. And the very important point is there is no interference with the exogenous given insulin. So when you give insulin to a patient and then try to see insulin, then it's very much likely that you may be measuring the exogenous insulin, not the endogenous production of insulin. But at least when you are looking at the C-peptide in the form of C-peptide test, this exogenous insulin is not going to interfere with your interpretation. It's not going to interfere with the endogenous insulin because it's not going to be assayed in the assay of C-peptide. So these are various points which make C-peptide a much better tool to assess the beta cell function. Now, how do you measure C-peptide? Now, C-peptide estimation can be done in a fasting state. C-peptide estimation can be done in a stimulated state also. And we know that in endocrinology, whenever we want to establish deficiency of some hormone, we need to get a stimulated value that may be differentiating between normal and the deficient patient much better than the fasting levels. So we have some stimulation tests available, and the C-peptide can be stimulated after a standard or mixed meal. And if you're taking multiple samples after mixed meal, this will be called mixed meal tolerance test. Or you can give patient oral glucose, then this will be known as oral glucose tolerance test for C-peptide. Or a shorter method may be that you can inject the patient with glucagon and then collect the sample for C-peptide within some minutes. And so you can do this test much in a shorter time. And then we can also measure C-peptide in a random situation, provided blood glucose, the plasma glucose is more than 100. Now, what happens is that whenever the plasma glucose starts falling, the beta cells get inhibited. And if plasma glucose falls below 70, the beta cells shut off their production of insulin. So this becomes a very strong inhibitory factor for beta cells to stop producing insulin. So whenever you measure C-peptide, you have to see that there is circulating plasma glucose, which is more than 100, which can keep stimulating beta cells so that there is production of insulin and C-peptide from the beta cells. So whenever you take a random sample, what you have to establish is that you have to make sure is that the glucose level is above 100. And we know that anything above 180 to 200 plasma glucose stimulates the beta cell to its maximum extent. So anything above 100, we can say that beta cells are being stimulated, and so we can consider it as a stimulated beta cell response to glucose. Then you can also measure C-peptide in urine, because we said that 5% of circulating C-peptide is excreted in the urine, but this is a cumbersome test. And then you can see the C-peptide against the creatinine, and this will be known as urinary C-peptide creatinine ratio. This is a non-invasive method, and very hardly any clinical facility will be using it, except this may be useful in particularly very small kids where it's difficult to get IV sample, and there it may be having some usefulness. But more or less, you can ignore this test. Remember that majority of endocrine deficiencies are proven by a stimulation test, and here we can stimulate the C-peptide by either a mixed meal, and we said that 90 minutes after a mixed meal there is a maximum level of C-peptide, so we can take a postprandial sample for C-peptide at 90 minutes after the start of meal. That may be one of the very easy way to assess the beta cell function. Now, how we do the glucose stimulation test? First, we ensure that the plasma glucose is about 70 milligram per deciliter, so that the beta cells are not inhibited to produce insulin and C-peptide. Then we insert a venous cannula, take a sample for C-peptide, for plasma glucose and C-peptide at 0 minutes. Then we inject glucagon through the IV cannula in 10 seconds. 1 milligram is injected, and you collect the samples at 2, 4, and 6 minutes for C-peptide level. So here we can have a very small test where we can give glucagon and take samples within the minutes, and we can send it to laboratory for C-peptide estimation. But more practical and more suitable test is mixed meal tolerance test, or sometimes oral glucose tolerance test. Here you ensure that patient has at least fasting glucose of more than 100. Insert cannula, take a sample for C-peptide or glucose, give the patient a mixed meal or 75 gram oral glucose, and take samples at 30, 60, 90, and 120. Remember, this multiple sample taking is usually required for some research work. In most of the situations, what is needed is just one sample at 90 minutes. And then we can also have a random C-peptide. Again, we have to ensure that the serum glucose is above 100. Take a single sample for C-peptide after glucose or after a mixed meal, and take a single sample at 90 minutes. So this is the standard and most accepted test, that you take a sample 90 minutes after the patient has started consuming mixed meal. And here is a slide which shows that how these tests can help in both fasting, random, and glucagon stimulator. Now, suppose you want to differentiate between whether patient is suffering from type 1 or type 2. Now, we know that most patients with type 2, when at the time of diagnosis, may be hyperinsulinemic. This is because they have a lot of insulin resistance, and beta cells are trying to cope up with insulin resistance with producing more and more insulin. So you can see here that C-peptide test in non-fasting or random situation. And here, this is type 1 patients, and you can see, and these are the figures given in nanomoles. So 1 nanomole is equal to 3 nanograms. And in our country, most of the reports come in nanograms per ml rather than nanomoles per liter. So you can say that if you are considering type 1, they have very little insulin, type 2, and this is their random or non-fasting of samples. If you take fasting, the differentiation between type 1 and type 2 still is very prominent, but still much less as compared to this difference. This is much less. And if you do glucagon stimulation test, this again difference is markedly more as compared to fasting. So we can say that mixed meal, 90 minute single sample can differentiate type 1 and type 2 with a very good margin of difference. So this is the most preferred test we are going to use in clinical situation. Now, there are certain limitations of C-peptide test, and we must realize that it's unreliable in renal failure. Whenever patient has renal failure, and we learned that C-peptide is mainly cleared by the kidneys, and so if there is any kidney problem, kidney disease, C-peptide may not be cleared, and C-peptide levels may be high in all patients who are suffering from renal failure. So this we must remember, that the C-peptide test is not valid if patient is having diabetic nephropathy and EGFR is something less than 60, then this test is not to be done. And initially, the tests available had lots of cross reactivity with pro-insulin, and so whenever pro-insulin will be high, the C-peptide automatically will go high, because there was a cross reaction between pro-insulin and insulin. This assay could not differentiate between two. But the modern assays now have this cross reactivity is less than 10%, which can be easily ignored. Now, C-peptide is a very unstable molecule. So if you take sample in a plain vial, let it clot and remove the plasma, and then send it for assay, this molecule may deteriorate. So this is very important to remember, that you should collect the sample for C-peptide in EDTA vial. And in EDTA vial, this sample will remain stable for more than 24 hours. And so many of our towns, they don't have facility to do the C-peptide test, and this has to be sent through some courier service, through some bigger labs situated in metro cities. So if you are taking samples in a plain vial and separating the serum and then sending it for the assay, this assay may not be a correct value, because the hormone is very unstable at room temperature and get deteriorated. So it's always better to take sample in EDTA vial. Patients on treatment with diabetes and plasma glucose of less than 100 milligram may have very low values. Doesn't mean that low beta cell reserve. Now, remember, we said that if plasma glucose starts falling, the body's first response is to inhibit the beta cells from synthesizing and secreting insulin. So what will happen is that if your glucose levels are already low because of some treatment, what will happen is plasma glucose says 80, 70, beta cells may not be producing pro-insulin, and so there is no insulin and C-peptide being produced, and you may falsely take it as that there is a very low beta cell reserve in the patient, but actually beta cells were present, but they were inhibited by low glucose. So remember that whenever you take sample, make sure that the plasma glucose is more than 100 milligram. Otherwise, this less than 100, there is a possibility that the low glucose have a very strong inhibitory effect on beta cells. So that doesn't mean that there is no, or there is low beta cell reserve. And there's a lack of specific reference ranges for different populations. Now, whatever we have is derived from the Western figures. We don't have our own normalized values for different populations. So this is also an hindrance. Lack of optimal standardization of various assay methods in the labs. Now, some labs are doing through ELISA, some are doing chemiluminescence, some are doing RIA. So their detection level and their accuracy may vary. And so the normal values may also vary. So remember this thing, that there is a lack of standardization, and assay methods may differ from lab to lab, and you have to really see to the value provided in the lab as reference value for normals, and then take the current value and compare it with that. Different units being used in different labs. Now, as I said, in our country, most of the times reports come in nanogram per milliliter. And many times, many labs and in Western countries, they are using SI units. And so they report it in nanomole per liter. This is equivalent to 1000 picomole per liter, and this is equal to 3 nano. So for 1 nanomole, which is the other unit very commonly used, so 1 nanomole is equal to 3 nanogram per ml. 1 nanomole per liter is equal to 3. So whenever you see a value in nanomole per liter, and if you are familiar with the nanograms, you have to just multiply it by 3. Another important thing to remember is that type 1 patients keep producing some C-peptide for few years after diagnosis. It's not a very instantaneous death of all the beta cells. It's always an ongoing autoimmune destruction of beta cells. And so many patients of type 1 diabetes, they keep producing C-peptide after few years of the diagnosis. And so we should always remember that It's not necessary that all patients of type 1 diabetes will have almost undetectable or very low level of C-peptide, particularly in first year or 3 years of the diagnosis of type 1 diabetes. Now, this is what I was telling you, that see the lower panel. Now, these are the pediatric age group patients who develop diabetes very young. And you can see this is the lower panel is showing the years after the diagnosis of diabetes. And you can see that if you have a cutoff on these, again, nanomoles, so you multiply it by 3, so 0.2 becomes 0.6 nanogram per ml. So you can see that if you have a cutoff of 0.5 nanomole, that is 1.5 nanogram per ml, and after stimulation you take 1.5 nanogram per ml as a cutoff, you can see even 11% patients may be producing more than 1.5 nanogram per ml after stimulation in type 1 diabetes, and this level will fall gradually as the patient's duration of diabetes increases. And then you can see that at 0.2 nanomole, that is 0.6 nanogram per ml, if patient is already having diabetes for more than almost 97% patients will have it. Against this, you take the LADA patients, latent autoimmune diabetes of adults, which is again a type of type 1 diabetes, which is having smoldering cores. So here you can see that much higher number of patients may be producing insulin, and this is how they are not going into decay for a few years, and they may be responding to oral hypoglycemic drugs. And so you can see, but as the time duration increases, their insulin levels keep falling. And so this the stimulated value of 0.6 nanogram, almost 92% will have that over the course of next few years. Now, what is the utility of C-peptide test for classification of diabetes? Now, you know that we make the diagnosis of type 1 diabetes on the basis of few criteria. Now, these are near absolute insulin deficiency. That is, these patients are unable to produce insulin from their beta cells, or they are producing very, very low amount of beta cells. Then we have specific antibodies like GAD antibodies or islet cell antibodies or insulin autoantibodies. So these are almost very strong indication for type 1 diabetes, relatively younger age of onset. So if the patient develops diabetes below the age of say 20 years, 25 years, then it's more likely to be type 1. After the age of 20, 25 years, it's more likely to be type 2. And these patients usually have a low BMI. So these are various possible criteria for making the diagnosis of type 1 diabetes. Now, C-peptide test is the best tool to determine near absolute insulin deficiency. That is this first point, what you want to establish when you are confused whether the patient is suffering from type 1, type 2. You want to show that there is very negligible amount of C-peptide, or there is no C-peptide being after stimulation being produced by beta cells. So this is one of the very good tests to differentiate type 1 and type 2. It has a better predictive value than age of onset and BMI. As compared to these two parameters, this has much better predictive value for type 1 diabetes. Most type 2 diabetes patients have hyperinsulinemia at the time of diagnosis, and hence C-peptide level is high. So we know that type 2 diabetes, a major component is insulin resistance. And to overcome insulin resistance, initially beta cells are producing more and more insulin, and then at some point of time there starts exhaustion of beta cells, and so these patients start developing hyperglycemia. So at the time of diagnosis, majority of them have a good insulin level available in the blood. So C-peptide is also high. So MODY and LADA patients have intermediate values. Now, this MODY and LADA, they have some values in between type 1 and type 2. And so for confirming diagnosis of LADA, that is basically type 1 diabetes, we need some antibody test, which may be GAD antibodies, insulin autoantibodies, or islet cell antibodies. And for MODY, actually you need some genetic analysis, gene analysis to make the diagnosis of MODY. Now, this chart summarizes some clinical situations where you can use. So we'll be concentrating on stimulated tests because that differentiates between the various categories of diabetes much better than the fasting levels. So when we say that there is absolute deficiency of insulin, there is absolute need for exogenous insulin, after stimulation, you concentrate on nanogram per ml. So we will say that if after stimulation, the C-peptide level is below 0.6 nanogram per ml, then this means patient is either having very low or no insulin available. There is beta cells are not functioning, and in type, this is likely to be type 1 at the time of diagnosis, or this may be a patient of type 2 diabetes who has lived say 8-10 years, and now there is very little beta cell functioning have left, and this type 2 may be requiring insulin. So it's a indication for insulin requirement. Likely type 1, or indication for initiation of insulin. So if you have a stimulated value of more than 1.8, this means or less than 1.8, this means the patient is likely to be type 1, or maybe uh, he is type 2 who needs insulin. Suggests type 2 or MODI in presumed diagnosis of type 1 after 2 or 3 to 5. Now, this also is not uncommon that we made a diagnosis of type 1 diabetes. A patient was put on insulin. After 2 or 3 years, there was some need to revise the diagnosis, or sometimes what we see is patient themselves stop taking insulin, and we find that their glucose levels are not going very high, or somebody has started them on oral drugs and patient is responding. Then there comes a problem that whether patient was actually type 1 or not. So here, after 3 to 5 years, if the stimulated level is more than 0.6, that means that probably the diagnosis of type 1 was wrongly made, and these patients may be type 2 or maybe MODI. Consider MODI or type 2 in young onset diabetes at the time of diagnosis. So if your stimulated C-peptide is more than 3 nanograms per ml in a young patient, and you are in dilemma whether patient has got MODI or type 2 or type 1, but if it is more than 1, then probably more than 3, then nanogram per ml, then probably patient is more towards type 2 diabetes or MODI than the type 1 diabetes or LADA. Now, C-peptide may also have some prognostic value. If you see in type 1 diabetes, now many patients continue to produce substantial insulin and C-peptide after some years of diagnosis. So we saw in a slide previously that C-peptide may be available, may be synthesized and secreted in circulation after some years of diagnosis of type 1 diabetes in some patients. Now, in DCCT trial, the patients with post meal mixed meal tolerance test for C-peptide, if their C-peptide levels was more than 0.2 nanomole per liter, that is 0.6 nanogram per ml, had lower HbA1c, markedly lower incidence of retinopathy, nephropathy, and hypoglycemia. So if your type 1 patient has something which shows that beta cells are left and beta cells are still functioning, that means that this patient is likely to be having better control of HbA1c, and he'll less likely to develop retinopathy, neuropathy, and even hypoglycemia. After islet cell transplantation, suppose a patient of type 1 diabetes undergoes islet cell transplantation, the C-peptide test is used as an indicator of graft survival or graft failure. So this gives an idea whether those transplanted beta cells are functioning or not. Now we see patients of type 1 diabetes who sometimes enter into honeymoon phase. Suppose a child develops a DK and had say a bout of chicken pox. You treated him for DK. After sometimes what happens is child's insulin requirement goes down, and ultimately you may have to stop insulin, and this honeymoon phase may last for a few months and sometimes a year, and then it becomes very difficult when to start insulin again. So C-peptide test can tell you, guide us when to restart insulin. So most patients may have a short-lived honeymoon phase. The honeymoon phase may be very short, few months only. And ultimately, these patients will start requiring insulin. So C-peptide test can tell you that this patient has now entered into near absolute insulin deficiency, and so you should start insulin. Now, whether C-peptide has any prognostic value in type 2 diabetes? Yes. So we have some clinical situations. Now, if stimulated C-peptide test is less than 2 nanogram per ml, that means there is a severe beta cell deficiency. Most of these patients have lived with their type 2 diabetes for more than 10 years, and this patient now needs insulin as the treatment. So oral hypoglycemic drugs now are failing. You don't have sufficient beta cells to respond to these drugs, and so these patients may require insulin. If the stimulated C-peptide level is in between 2 to 4 nanogram per ml, then that shows a moderate insulin deficiency, and these patients are likely to respond to lifestyle management and OHA, and these patients may continue to take OHA for some length of time. And if your stimulated C-peptide test in a given patient is more than 4 nanogram per ml, this clearly indicates that lifestyle management may alone work. That is, lifestyle modification measures can work, and even if patient follows some strict regimen of dieting and exercise, he may reverse his diabetes for a few years. So this shows that there is very robust beta cell reserve is present, and these patients can respond very well to lifestyle management. Now, if your stimulated beta cell, the C-peptide level is between 4 to 6 nanogram per ml, and your patient is very obese, and he wants to undergo bariatric surgery, and he asks you what are the chances that my diabetes will reverse, it shows that 90% chances that there will be reversal of diabetes after bariatric surgery. So all those patients who are very obese, who are diabetic, and they are planning for bariatric surgery, and if they ask you whether they will have reversal of their diabetes, so you can do a C-peptide stimulation test, a mixed meal, 90 minutes after take a sample for C-peptide in a EDTA vial and send it for estimation. If the value is between 4 and 6 nanogram per ml, that shows that patient is very, very likely to have reversal of his diabetes. Now, high C-peptide level with high fasting glucose indicate insulin resistance. So in any patient, if he's producing more insulin against the glucose value, that means there is a lot of insulin resistance, and so these patients are more likely to respond to lifestyle management, metformin, and the drugs which can address the insulin resistance like metformin and pioglitazone. Now, other uses to differentiate between factitious and exogenous insulin-induced hypoglycemia and insulinoma. Now, these are situations where sometimes some patients are purposely injecting insulin to produce hypoglycemia. We rarely see patients to avoid examination, sometimes avoid marriage. They inject themselves with insulin, and so C-peptide, exogenous insulin does not contain any C-peptide. So you can differentiate between whether it's because of the exogenous insulin or endogenous production of insulin by doing this test, and maybe as a marker of response to metformin in patients suffering from polycystic ovarian syndrome. So in polycystic ovary syndrome, fairly commonly seen, and so sometimes whether this patient is going to respond to metformin, you can resort to C-peptide test. So in take-home message, we can say that C-peptide test is one of the best biomarkers for endogenous insulin secretion. Samples should be taken in EDTA vial, and when taken in EDTA vial, they are stable for 24 hours. Stimulated C-peptide 90 minutes after mixed meal can differentiate most cases of type 1 versus DADA from type 2 diabetes. That is, whenever there is a problem, whether patient at the time of diagnosis is having type 1 diabetes or having type 2 diabetes, this is a very good test. This test can be performed even in patients who are on insulin. So if patient is taking exogenous insulin, if the glucose levels are above 100, you can do C-peptide test and see whether the beta cells are functioning. This exogenous insulin is not going to interfere with the test. And if you are doing insulin, this is definitely going to increase the level of insulin as you assess by the test. In renal impairment, C-peptide is high and not valid for interpretation because most of the C-peptide is cleared by the kidneys. So if there is a kidney disease, C-peptide will accumulate in the blood, and so the results are going to be high, and this is not valid for any interpretation. In type 2 diabetes, C-peptide test provides a prognostic value for choosing the treatment. So which type of treatment you should choose? Some indication can be given by this particular test. Suppose your patient wants to undergo bariatric surgery and asks you whether he'll have a reversal of diabetes, you can do C-peptide test. And whether your patient needs insulin, sometimes some patients they insist that doctor, you tell me that I'm not producing insulin from inside, and then only I'll start my insulin as advised by you. You can go for this test and tell them that, see, your C-peptide is very low, that means you are not producing insulin, and so you need insulin from outside now. So thank you very much. I'll be very happy to answer any questions you have. So Dr. Subhashnath, endogenous insulin resistance, why fails to control sugar than that of exogenous? Okay. You can see you have insulin resistance. That means suppose you inject a person with 1 unit of insulin, and normal person, the blood glucose goes down by 10. In a person who is suffering from insulin resistance, you may have to inject 4 units of insulin to bring down the blood glucose by 10. That means there is a lot of insulin resistance. That means that you have to increase the level of insulin beyond the required level of 4. Then only you'll have a drop of insulin, by drop of blood glucose by 10. So this is, suppose I want to buy a suit, and I have only 4,000 rupees, and suit comes in 5,000 rupees. What will I do? I borrow 1,000 rupees, and then I can buy a suit. The same is true here, that if your insulin is falling short because of the insulin resistance, you have to resort to exogenous. You have to buy insulin from outside, but take a loan of insulin from outside. Okay. Then there is stimulated C-peptide 90 minutes after mixed meal. Mixed meal means normal meal. Yes, initially there was a standard mixed meal. Now they say that you can take any normal meal, but it should contain adequate amount of carbohydrates. More than they say something like 60-70% of calories should come from the carbohydrates, so that there is sufficient stimulus for beta cells to produce proinsulin, which gets cleaved into proinsulin and C-peptide. Dr. Utkarsh Singh, sir, 60-year patient came to me as the previous diabetologist was not able to manage the sugar with 4 or 5 OHA drugs, and he was refusing to take insulin. I checked C-peptide and it was very less. I convinced him that insulin, but to do what to do about OHAs. Now, if you see the guidelines, now the initiation of insulin most of the times is done by basal insulin, and most of the times you can continue the current OHAs, but many guidelines say that you should stop giving them sulfonylureas. But what we believe is that there's some amount of beta cells still left. So if you can use them by stimulating with sulfonylurea, I can even continue sulfonylurea. But if patient has already lived with type 2 diabetes for more than 10 years, most of the patients have very negligible beta cell function. Dr. Jiten Jain, differences in application of fasting and stimulated C-peptide level. I told you that in a normal person, fasting is something like 0.6 to 1.5 nanogram, and stimulated is something like 1.5 to 2.5 to 6 nanogram per ml. So it's almost gets stimulated by 4 times from the fasting. Frank Kamal, difference between C-peptide and fasting insulin. Difference between C-peptide and fasting insulin. I think I've explained you that they are produced in equimolar concentration. For each molecule of insulin, there is one molecule of C-peptide. Insulin is being a heavier molecule having 51 amino acids, this being a lighter molecule. So if you go by nanograms, it may be different, but if you go nanomoles, you may have a comparable value. Then there is DKA patients, IDDM, C-peptide low on insulin. How to prevention attacks? See, when patients develop DKA, that is one indication of absolute insulin deficiency. That itself tells you that patient is having very negligible amount of endogenous insulin. And so most of the patients of type 1, if they develop DKA, if you do C-peptide, it's going to come very, very low, both fasting and stimulated. Then 90 minutes after meal, from the start, yes, it's from the start of meal. When you when the patient takes the first bite, then you start your watch. So there's a stimulated C-peptide 90 minutes after mixed meal. Mixed meal means normal meal. Yes, I told you normal meal. Then Dr. Varun, sir, what is the cost of C-peptide test? I think various laboratories they charge differently, but something in between 1,000 rupees to 2,000 rupees is the usual cost. Some laboratories are doing it, but much less also. You can say 1,000 to 1,200 is the usual cost. Effect of sulfonylurea no, sulfonylurea, you should remember. Sulfonylurea work by stimulating the beta cells. So any patient on sulfonylurea, if he is having type 2, is likely to have a higher C-peptide level. At which age C-peptide level should be measured? There is no age-like thing here. Actually, what happens is we order this test in most situations where we are unable to make a diagnosis whether patient is suffering from type 1 or type 2. And this happens usually in patients who come in teens, that is in between 10 and 20 years, or sometimes 20 and 25 years. Then you are unable to make a diagnosis whether patient is really type 1 or type 2. Some patients of uh, type 1 maybe may not have lost so much of weight that their BMI is low, and then in those situations you may need this test. C-peptide level in type 2 treating with secretagogues versus non-secretagogues. Definitely those patients who are taking secretagogues like sulfonylurea and say miglitinides, they will have, but this is sort of a stimulation test for them. We can give them mixed meal, we can give them glucagon, and you can also give them sulfonylurea drugs to stimulate the beta cell to produce an. If so, any value which comes after stimulated value which comes in a stimulated normal sort of a value, that means that they are producing insulin. To differentiate type 1 to interpret C-peptide level, I've already given that in one of the slides. I think these are the most of the questions now are being repeated. I have already answered. Can exogenous insulin reduce the endogenous? No. You mean to say that if somebody is on exogenous insulin and if the glucose levels have started falling below, say, 100 milligram, the beta cells get inhibited, and so C-peptide level will stop falling. If the glucose levels reach around 70, there may be complete shut off of the beta cells from production of insulin and C-peptide, and so you can imagine that any patient after exogenous insulin, if it is responding to insulin and having less than 100 milligram per deciliter of glucose value, that means you are actually trying to inhibit beta cells, and so the values may be different. I think that's all we had. In the chat box, I hardly have any more questions now. Thank you, Shobit.